everyone. Yeah, thanks for coming to the breakout session. Uh, I think the whole point of this is basically we have a more focused discussion with what kind of work plans do we want to have as a group going forward for AML. Suggestions. Oh, this is Prof. Way's thing. Yeah. So suggestions include how are we going to coordinate our registries? Maybe have uh, a more unified data set which we can publish in terms of what are the outcomes, what kind of outcomes of AML we're achieving for Asia Pac. Consensus guideline being another possibility where we are looking into either a more broad guideline. I understand that regionally there are very quite wide differences in terms of access and even uh, what kind of tests do we have and access to treatment. So that's another thing we can discuss. And the third thing is, of course, clinical trials. Given that AML is such a difficult disease to attain cure, how as a regional work group, how can we come up with trials that are more tailored to our own population? I was just thinking maybe to start off, we go around the table introducing each and one, everyone of us, and we get to know everyone. Yeah, I'll start first. I'm Zhen Tang from Singapore General Hospital. I'm a senior consultant in hematology service, and my subspecialty is acute leukemias and MDS. So I've been actively involved in the trials and do some basic clinical research. Yeah.
Hello again. So Mike Aiken, I'm the Asia Pacific Medical Director for Janssen in Hematology.
So, Dr. Pimchai Nipalak from Ramathipudi Hospital, Thailand. Yeah, I'm interested in the acute leukemia and transplantation.
Hi, I'm Lynette Chi from Peter MacCallum Cancer Center in Melbourne, and I look after AML MDS patients, and I also look after myeloproliferative diseases patients, and I also do allografts.
Hello, I'm Jamie Yan. I'm based out of Singapore. I'm the medical director for Zospada, covering international markets in Greater China, which covers APAC, Latin America, and Middle East, Africa, and Russia.
Hi everyone, I'm Xian Ho from National Taiwan University Hospital, and my clinical and research interest is myeloid including AML, MDS, and MPN.
Hi everyone, I'm Hui Wei from Tianjin, China. I'm in hospital, blood disease hospital. My specialty in acute myeloid leukemia.
Hi, Hija Kim from Seoul St. Mary's Hospital. My specialty include AML and allotransplantation. Nice to see everybody.
Hi, I'm Jing Jie from the First Field Hospital from Zhejiang University School of Medicine. I focus on leukemia, especially AML.
It's Jianxiang Wang from the Institute Hematology Chinese Academy of Medical Science located in Tianjin. So also my major work focuses on acute leukemia, also so some work chronic myeloid leukemia.
Hi, I'm Yvonne Lo from Mount Elizabeth Hospital in Singapore. Special interest in AML and transplant.
Hi, my name is Melissa Uy. I'm from National University Hospital Singapore. I'm interested in acute leukemia, myeloma.
Hi, I'm Jay from Kuala Lumpur Gleneagles Hospital, a general hematologist.
Hi, I'm Jerome Tan. I'm a clinical hematologist in Hospital Ampang in Malaysia. I see general hematology, but AML forms the bulk of my work.
Hi everyone, I'm Deepa. I'm from Singapore as well. I work in this hospital called Tan Tock Seng Hospital, which is one of the government hospitals as well. I'm sure you haven't heard about this before. We treat all cancers, like we don't, every hematologist treat all hematological malignancies, but we do have a special interest, so mine is acute leukemias.
And Andrew Way from Melbourne. So in terms of some of the things we could do as a group, from the discussion before, obviously the P53 mutation situation seems like a major problem. One thing that occurred to me was, would there be any interest from the group to perhaps look at a collective publication and study on the outcomes of patients with P53 mutation? Obviously, they're going to be bad, but really just to exemplify how bad it is as a starting ground for future trials looking to come into the area. So what we could do is identify patients who have a P53 mutation, so we have a denominator, and really the questions are, a little bit about the P53, VAF size, etc., what therapies were given, the response rate, what proportion got to transplant, and then what the outcomes were post-transplant. And if we have a common sort of data sheet to put the patients into, it could be collated and then could be published. And if there's somebody that would like to lead that exercise, it's something we could consider. So any thoughts as to whether you think that's of interest, whether it's feasible, and if anyone would be interested in leading that type of exercise in terms of putting together a data sheet and then circulating it and then seeing if there's enough interest to contribute to it. Anyone? Because we haven't looked at our own patients in terms of, we all know it's bad, but we've never actually done a formal analysis. And so I just wondered, has anyone done an analysis of their own P53 mutant cases in their own institution so far? Retrospective, yeah. And so if no one's done that yet, then obviously it'd be nice to do it, but it'd be more powerful to put it together as a group exercise would be my thinking.
One study that wasn't exactly TP53, but it was looking at monosomal karyotype. That was before we had those testing. So similar, but not exactly TP53.
Yeah. Yes, Sana?
Yes, I think it's very important to integrate the data from Asia Pacific area because I think the health system is quite different from Western countries. For example, in Taiwan, we have the Taiwan AML registry. We want to analyze the epidemiology, cytogenetics, and molecular data, and also treatment outcome. And so I think I'm happy if we have such alliance to integrate all of the data compared to different treatment outcome. I think it's very important. We can know the major needs in this area and how to improve this situation.
Sorry?
Are you volunteering for your own region or you're going to take up for everyone? So you said you have a registry, right? So
yeah, I think it's a very open question. So I think like any kind of cooperation and for any project, I think it's a very good idea.
Okay, if no one takes it up, maybe I'll do it.
Yep. Okay.
Provided it's in time.
Yeah, I'm totally fine.
Okay,
Yeah.
give me your support. All right.
Sure.
So maybe you'll have to just get the contacts to get a group email going. Send around. Do people prefer Excel spreadsheets or RedCap, or what level of database do people feel comfortable with? Maybe Excel. Excel. Okay, so you can develop a draft Excel spreadsheet. Make it as simple as possible because when you have too much data, it doesn't work. And then we can see if it will suit everybody. Yeah. Does anybody else want to co-lead this? Two countries would be good. Someone from China, maybe. Yep.
Due to for NGS analysis, the routine work for us, so really we do screen many patients. We have some data about P53. Maybe we can contribute to this. Yeah, I think no problem for us.
I think it's important to have someone from China because you have so many patients, and so I think the majority will be from your country.
Yeah,
else like to contribute our data.
Yeah.
And we survey our from our hospital for AML 1,300 patients with AML, and P53 mutation is 100. That means 7.4%
Yes.
is mutation. Yeah.
Which is the quoted figure of P53 in AML.
Yeah.
And I think Dr. Ho's got 1,000 patients, probably 2,000 patients sequenced now. Is that right? So, collectively, it could be 5 to 10,000 patients, which could in fact be one of the largest, exercises on the planet. So, it just shows that the populations in these countries are huge, but it's doing it as a collaboration, which makes it really powerful. So let's see how this goes. Yes.
If we are collecting data, since everybody has to put in, if it's not too much trouble, do we want to look at other mutations as well of interest, or do we just want to? Because if we are going to have to fill up multiple.
Yes. My gut feeling is, as a first exercise, doing something focused is more likely to be successful. And if that's successful, then looking at other mutations next time would be good. But I just think P53 is the biggest problem, and there's not a lot published that I'm aware of in the Asian sort of Pacific region, and we all do sequencing now, and it should be fairly straightforward because the survival's pretty short. Yeah, but I absolutely agree with you that if we get the model right and the spreadsheet is easy to use, then any question can be asked next time of interest. Definitely for publication, it's easier to publish something when it's very focused and there's a clear question, as opposed to all AML and then the message gets very blurry.
I think to add on is that also we do have a registry group that is working towards unifying the registry, so that will be something ongoing in the future. Yeah. So I think for now, yes, it's probably good to make it focused and easy, so that we have quick outcomes that we can show that we are, achieving things. Yeah.
My only other suggestion is we recently published this. There's about 30% of patients who have chromosome 17 changes without a P53 mutation, and it's worth including those because they're pretty poor prognosis. Yeah.
I was just going to say, I think as Dr. Ho has mentioned, it'll be very important to collect the cytogenetics data as well, because there have been studies that shown that if you don't have the concurrent deletion 17p or complex cytogenetics TP53 mutated EMLs don't do as badly after allografts, so it'll be important to collect all of that too.
And I guess with this exercise, we'll have a lot more patients with the low VAF, so we can have greater clarity as to whether this is really a bad prognostic subgroup or not, especially if there's a lot of patients.
Okay. From Thailand, we can. I also share our data, but it's just small number of the patients because I used to analyze the data. Just only 9% of our patients at de novo AML that have the TP53 mutations, and maybe 20 to 30% of secondary AML, and around 50% of therapy related AML that have the TP53 mutation. So in Thailand, the problem is not all of our institute that do the next generation sequencing. So I'm not sure from my center. I can share this data, but maybe a small number of patients.
And the last thing is maybe just to make sure everyone's data is, protected, is to consider sending a material transfer agreement that the submission of the data can only be used for this purpose and can't be reused for anything else unless there's approval from each centre.
What's the other thing? Guidelines, right? But also, I think continue with what Melissa was thinking. Do we have any wish list? In terms of what we are trying to look at in the future after TP53.
I think we should probably talk about trying to potentially, since all of us have registry data, to see what our commonalities and differences are, and to see whether we can actually, make them quite similar. So if you ever want to share data or do collaborations, that would ease the administrative work.
So we are working on that also, but yeah, it's taking a while. So because I think Ashley has engaged one of the commercial companies, so I think they are working on how to, because they can modulate the data that comes in. So we are
I don't know. I mean, we have that collaboration from the myeloma group, so we can probably take a page out of their
Guidelines.
So the second thing is we were talking about guidelines. At least from the survey, we do get that there's quite a big disparity in terms of access to what drugs and everything. I think as a first step, maybe a kind of would you think a diagnostic guideline, because frontline, I suspect it's pretty uniform, but in terms of diagnostic and guidelines and how to segregate patients into treatment eligible, chemo eligible or ineligible, transplant eligible, ineligible, as a first step before we move on.
Can I ask, do any of the countries currently have any locally developed AML guidelines? National guidelines?
We have a broad one. We have
Singapore, yes.
We have a broad.
We did our own local guidelines, and I think we got it published in the local Academy of Medicine.
Yeah, but no one's to accept it, so we couldn't.
Thank you.
Yeah.
Because it kept changing. When we write the guidelines, then
Because we're really slow.
Yeah. Dr. Ho?
Yeah, I think I would like to share the experience from Taiwan. Taiwan, we have a AML treatment guideline, and this guideline is in cooperation with NCCN guideline. So we have paid money to NCCN guideline. But according to this guideline, we made some amendment because some treatment is restricted Taiwan only due to the resource limitation, but we will give some reference to support this treatment. I would like to suggest that we can divide it into several groups. Some group is focused on diagnosis, another for resuscitation, and another for treatment. And for me, the best guideline of AML must include diagnosis, resuscitation, treatment, and not only frontline but also relapsed refractory.
Any other guidelines, Dr. Wang?
Of course, it's a very large country. We have all own guideline for AML, AL, myeloma. Every maybe for hematologic malignancy, their own guidelines. But especially for the AML, we have all specific regimen. For example, hemorrhagic is quite unique in our country. Also, use hemorrhagic as a basic regimen combined with cytarabine, aclamazine, or daunorubicin. Also, even for the counter remission and long-term survival is better than typical 3+7. So it's widely used in our country. So basis on this kind of achievement, so we have our own consideration for the choices of the therapy or AML compared to the NCCN or ERA recommendation. Also, we have something different in our guidelines.
Within China, are there regional differences in practice as well, or is it quite similar?
Yes, I think some difference. The difference really from the dosage selection. For example, for the 3+7 or for daunorubicin dosage, in some hospital maybe still use 45 milligram per square meters, but usually in the large cities, very good center use 60 milligram or 90 milligram per square meters. But this is different due to the supportive care in different hospitals. Yeah.
So it sounds like the treatment is a little bit more unique in China compared to other other areas where we don't have access to Homo harringtonine and aclarubicin, etc. So maybe for this guideline purpose, it sounds like it'd be like China and rest of the world type of situation. So if there are groups outside of China who feel that some national guideline endeavours would be worthwhile, then perhaps someone could lead a subgroup. Now in Australia, so we had the same problems, and so within our cooperative group, we decided publication was challenging because every time you publish, it changes and becomes irrelevant. So what we've done is we've created a document which lists our recommendations for frontline therapy, and then we update it every 3 months. And then it's available on a website, and then anybody can download it. But obviously, it's not going to be relevant for every country because we also put in all the compassionate access options as well, so that doctors in all hospitals know when CPX is accessible. Otherwise, it's unfair if only some doctors know and not other doctors. So if somebody is interested in looking at, actually, you shouldn't use the word guidelines because it carries legal connotations. So we call them treatment recommendations. So if somebody wants to do some treatment recommendations, then the people that already have some documents, we could pass them all on to them to review which format they like the most, and then consider something that will be then passed around to people that need them, and then they would just edit them to make it locally specific. But then you need to have some website where it can be uploaded so people can access it. Whether the APLC could do that, I don't know. But those are the issues to consider. Yeah. So does anyone feel strongly about wanting to develop recommendations, and who would like to take a bit of a lead on that? Not Singapore. All right, it's a bit of work, but so no one's so strongly wanting to volunteer for that one. Dr. Ho.
I think I can share AB1, the Taiwan AML guideline is an English version. And we show some, just like I mentioned about, is resource limitation. So we have some amendment such as the 2+5 treatment regimen, because this regimen is not recommended in NCCN guideline. So maybe we can use this as a template and make some amendment. And even Taiwan has a treatment guideline. The guideline adherence is another important issue. So in this years, we want to follow up the treatment and adherence to make sure.
Adherence,
yeah. I think so, to make sure everyone can stick to the guideline. Yeah. So I think maybe in the near future, and the guideline adherence is very important.
All right. So what we could do is we could just share our treatment recommendation documents where they're available to the group, just so that people can see what type of format people have used. Are there any other countries where they have some treatment recommendation documents that they'd be happy to share?
We can share.
Yeah.
Yeah. So the problem is ours
doesn't matter.
Yeah. Ours is quite basically all encompassing.
So maybe we just need someone who's happy to receive them and then distribute them as maybe a collated document. We can send them all to you, and then you can send them around. Okay, perfect. All right. The third topic was, and the most difficult one is trials. Now, in terms of doing trials, this is difficult because obviously trials are not a minor undertaking, and to come up with a clinically relevant idea, drug supply, etc., it's not easy. So I don't underestimate the complexity of this task. But I just wanted to ask people if there was an IST that would provide access to gilteritinib for older people who are struggling with Venaza. So the option would be FLT3 mutant, start with Venaza, and then when the patient is unable to keep going on Venaza because of non-hematopoietic toxicity, frailty, or delayed count recovery, if we could provide gilteritinib to continue, would you be comfortable in collecting that data for a grouped analysis? Is there a need for that type of therapy? So this is not patients who are primary refractory to therapy, and this is not for patients who've got FLT3 relapse, because that is the commercial indication for gilteritinib, but it's Venaza morphologic response but unable to continue, then switching to gilteritinib with the desire to collect some DNA storage time points along the way so the MRD can be assessed. Maybe we can just go around to see if that's of any interest. Dr. Kim?
Do you mean as a prospective trial?
Yeah.
Sponsoring Stellas from Stellas? Really?
They're interested.
I'm not sure.
They're interested, yeah.
If it's positive, sure.
Yeah.
I'll participate.
Yeah.
Good news, but
So we wrote a synopsis this morning, given it to Jamie, and she's circulating it to the bosses. And Jamie, what's the impression? No pressure.
I think the initial concept that you had verbally communicated is received positive, because this is a data gap for Stellas as well. But I think specifically on the drug supply question, there are just some logistics matters that we need to check internally. But I think the current concept looks much better, so we will have continued conversations and let you know. But I think we're very interested in collaborating with this group.
So the requirements would be Astellas has to have a distribution arm in the country, because we can't set up distribution centres. So as long as Astellas is happy to distribute the drug in that country, that's yes. The second thing that's unresolved is how long they're prepared to provide the drug supply for. I've suggested that patients will be on average on therapy for about 6 months, but whether they're happy to provide therapy if someone's on therapy for 24 months or whether there's a cut-off is the question. My preference would be that patients should be able to stay on it for as long as they need it, but the average drug supply calculations would be around 6 months per patient. Yeah.
So one of the key things we'll be interested in, how do you decide on discontinuation in respondents?
So we can discuss. So the thought would be patients would go on until either progression, intolerance, or death. I mean, if a patient is well and in remission, would there be a desire to stop therapy, or would people just keep going? And if there was a stop, what would be your comfort zone if patients were in remission and doing well? Would you stop at 12 months, 2 years, or different?
I would think we will need the NGS PCR to determine whether it's safe or not, right? In this case, it should be a paired study with that, if possible.
Would a maximum of 24 months be a compromise? I don't think there'd be many people alive at 24 months, so I think if they're still on therapy and not progressed at 24 months, they're probably all right. 24 months?
The target population would be the elderly,
Yep.
60 to 70
Yeah.
something, so not that many. Expected not that many people
15%.
enrolled, so
Yeah.
it's feasible, but I think it depends on the country's condition. Every country, the condition is very different.
Yeah.
In South Korea, not that beside the drug, there's some kind of supportive the facilities, or some kind of supportive drug, sometimes transfusion, something else is required according to the Korean regulation or something. So I'm not sure whether it's possible to get the drug, just only get the drug, but something else would be problematic. So anyway, it's good trial, but have to check it out. All countries, different situation.
Yep. So we'd have to do a feasibility as to which countries would this would work in as well, obviously. Yep.
Can I check if this trial is a go? Then would we then be able to send centrally banked samples to Australia for the flow NGS?
I've done a preliminary schedule of assessments where at around 3 monthly intervals, just some DNA is stored. And my thought would be you store it locally. And then at the end of the study, if there's no other centres able to do the FLT3 MRD, then yes, happy to receive them, and we can run them. Like, it's actually very cheap, so we can run it's a 96 well plate on one mini-seq run. It takes 2 days, and it's very cheap. So for us to do 400 is no problem. Yeah.
Suggest if money is a problem in terms of what Astellas is willing to provide, should we think about cutting down the duration of therapy to maybe 12 months so that more countries can have access? Obviously, if they want to give 24 months, that would be great. But I think that if it's a cost concern,
well, I think the cost would be averaged on. My suggestion is 6 months, and then
up to.
No, average of 6 months. So there may be some patients who do get 24 months, but they will be like 5%. And there'll be a lot of patients that don't go beyond 3 months. But on average, the drug supply for 6 months would be about right. And the suggestion was 100 patients.
Can I just check, based on the Admiral, I know it's a different cohort, but on the Admiral cohort, how long have the longest patients been on after they have resumed, either it's before transplant or after transplant, or whether they've just continued on the drug?
There are patients who went beyond 4 years, but I'll have to check out the actual numbers. But the long-term data, I think we are beyond 4 years.
So there'll be some attrition for sure, right? Yeah.
And the other thought to make it more feasible is not to collect full AE profiles, because we're not interested in the tolerability, but just to collect adverse events of special interest. So that would just be differentiation syndrome, pancreatitis, PRES, and just things of unique to the drug, QT prolongation, but not to collect everything.
So one of the ways we were thinking of as a start for the trials is that we don't make it a full collaboration where there's a lot of centralized processing of data, whereas rather than maybe each center has its own protocol, but it's unified. Everyone's doing the same thing. It's just that there's no central data processing or everything. But at the end of the trial, we collate the data, and so it's just individual small size IITs, and then at the end of the day, we combine the data, because I think otherwise it does what do you call it? It circumscribes some of the legal problems when it comes to making multi-center trials. Would that be something feasible?
So you're saying there that if there was an electronic data capture scenario, that's not going to be easy to do? Is that what you're saying?
I'm just thinking, because if it's multi-center trials with all different countries signing agreements, it takes a long time, right? But if it's just individual centers doing their IITs, whereas but of course we coordinate the protocols exactly the same, if feasible, center dependent. That circumvents most of the legal issues, and I don't know.
But that would mean Astellas would have to contract with every center.
That's the thing.
So we need feedback from Astellas, whether dealing with each country individually or just dealing with one sponsor is what would work.
With one sponsor.
Okay.
May I ask one question? I'm not sure that the inclusion criteria for enroll for gilteritinib, do you mean that the patient have the FLT3 mutation at diagnosis or before gilteritinib?
Yeah.
Because some patients maybe disappear before get the gilteritinib.
Can we scroll down to the eligibility criteria, whoever's got the computer? Oh. click. Seriously? Okay.
Yeah.
Oh, okay.
Sorry.
Okay, so these are the drafted eligibility criteria. So feel free to suggest. I'll run through this. So age 18, obviously excluding APL, FLT3 mutation at the time of treatment, presumably by capillary electrophoresis or something. Initial therapy with Ven/Aza, but Dr. Ho suggested we make a Ven/Aza, low-dose RSC Ven, and also Ven DAC. No evidence of active disease, so we'll rephrase that as no morphologic evidence of disease. Not able to continue Ven/Aza because of complications from Ven/Aza precluding further therapy, persistent grade 4 cytopenia beyond day 56, or patient too physically debilitated to continue Ven/Aza. So they're the main eligibility criteria, and very happy to modify those according to what people think. Lynette?
Would it affect your readout if patients have got differing numbers of cycles of Ven/Aza? I'm just wondering whether it might be better to standardize it and go CR Ven/Aza 2 cycles and then move on to gilteritinib, because otherwise you're going to have varied numbers of cycles delivered.
So then one issue is if someone's tolerating Ven/Aza well after 2 cycles, then would physicians feel uncomfortable at stopping at that point is the question. I did toy with the idea of a certain number of cycles, but then was worried that people would get to that point at different, like for instance, my last patient with the first cycle of Ven/Aza was completely untreatable because of severe sepsis. And so in that patient, 1 cycle was the threshold. So I suspect it's going to be a bit individualized, but I take your point. But the actual thought was that the participating centres would then do a historical analysis of their elderly patients for the last 5 years and look at their outcomes, and that the outcome of this will be overall survival going back to the first initiation of Ven/Aza, not at the time of, and that way you then have a stable time to event baseline. Does that make sense?
Or perhaps we can set an upper limit to the number of Ven/Aza cycles. I mean, if someone is 1 year out and might not have any more benefit getting killed. Right?
That's true. So maybe no more than 6 cycles or something like that. Yep, that's reasonable. Yep. Good idea.
I think another important reason for the discontinue of Azavan due to the ultra fabrication maybe is a atrial fibrillation.
Atrial fibrillation.
Yeah, also maybe the reason for can't continue to the other mental class also can enter the maintenance therapy for children, maybe as an inclusion criteria.
And the reason for this is that, unfortunately, for these older people, triplet therapy is not feasible. And then what else do we do if they're not going to transplant? We don't want to wait for them to relapse before we give them gilteritinib. So it's like a preemptive type of strategy. So for the physicians from China, do you think this type of study would work in your environment, or do you have again other unique treatment options that would rule out this population?
I don't think we have other options due to these reasons, so I don't think.
Okay.
Yeah.
Right. Dr. Zhen, do you think this would be feasible or appealing in your centre or not?
I think for the eligible patient must be unfit patient and elderly patient.
Yeah.
Yeah, we will use the VE plus AZA. Yeah, but I think it's okay. Not so much. So many patients will be enrolled.
Yeah, I think in each centre, probably I'm thinking maybe three or four patients a year.
Yeah.
So to need quite
That's
a lot.
okay.
Yeah. I'm not expecting this to be 25 patients per centre. No. Yeah. All right. Okay. So we'll stop discussion at that point, and I'll pass back to Lau.
I think that's all we have on the agenda. Does anyone have anything else you want to raise? What kind of projects you want to do with the rest of the group?
I would like to suggest that if we have a regular online meeting, I think it's very important to share some progress or some very interesting topic. Yeah.
I think it's I think APLC we can get our people to set it up and then make it a regular thing. Yeah. Maybe quarterly or something. Anyone else? Any suggestions?
Does everybody do NGS?
Maybe a show of hands who does NGS here. I think almost everyone. Almost everyone. Yeah.
Almost everyone. You showed us the data in the morning.
Yeah.
Almost everyone does.
Yeah. But that one doesn't encompass everybody because this is that was for focus group now. I think.
And just before we finish up, just the attendees from industry, were there any sort of questions you had to us or areas of interest that knowledge-wise that you'd like to bring up? We're not committing to doing anything, but we'd like to hear from you. Maybe Michael and then Jamie. And is there anyone else from industry around the table?
So nothing specific from me at the moment.
Okay.
I just wanted to understand from our perspective, I think the duration of treatment of the respondent, which I asked before, whether or not if you reach MRD negativity, does that actually then consistently apply for you to discontinue treatment? I think that to us is a big question mark because we see a lot of lack of consensus in terms of even post-transplant, how long you should keep gilteritinib treatment going.
Because the MRD assay is not widely available, I don't think that would be feasible at this stage to use MRD-guided cessation. But through the study, if we find that people are MRD negative at 12 months and they don't relapse, then I think that will be very much more supported. So I guess you just need to let us know if do you need us to put a cap on the duration of 12 months, 24 months, and then whether that would be acceptable to the group or not in the absence of relapse and MRD testing.
We'll look into it. Thank you.
Okay, I think we have come to the end of the meeting. I think it's just free and easy until dinner time. So a reminder to gather at the lobby at 5:30 for the dinner. 5:30, yeah. Okay, thank you. Thanks, everyone.